I first started getting symptoms of atrial fibrillation more than 20 years ago. It was a classic example of AFib in the sense that I had very rapid heart rate. It was almost to the point of being scary. My wife took me to the hospital. It's much more common than I ever thought. A lot of people have AFib and they just ignore the symptoms. I would encourage anyone who has the problem, rapid or irregular heartbeats, to see the doctor.
Atrial fibrillation is an abnormal heart rhythm involving the upper chambers of the heart. In atrial fibrillation, the electrical signal goes extremely rapidly in the upper chambers. I describe it as a windstorm or a sandstorm, just swirling around many hundreds of beats per minute.
A lot of people have funny sensations in their chest, palpitations, flip-flopping in their chest, and they just ignore it, or they don't know what it is, and they don't know that they may have a medical condition that's very treatable. The risk factors for developing atrial fibrillation include things like age. It's also more common in people who have hypertension or high blood pressure, people who have conditions like obstructive sleep apnea, obesity, things like that. Patients often don't feel well in atrial fibrillation, and it is the most common arrhythmia that affects adults in the US.
It's very important to make the diagnosis of atrial fibrillation. For some patients, atrial fibrillation presents a significant stroke risk. For other patients, it's really the explanation for symptoms that have really gone undefined. So they may have felt fatigue or shortness of breath with exertion that they never really realized why they were having those symptoms.
I think Stanford is unique in terms of our ability to take a look at the patient as a whole. We generally look at what the patient wants, what kind of medical problems they have. In addition, we can take care of the full spectrum of AFib, from the very early AFib to the very advanced AFib.
The atrial fibrillation program at Stanford is unique because it provides some of the most extensive range of options for the treatment of atrial fibrillation today. When treatment first started for atrial fibrillation, surgical techniques involved opening the chest. Those have now been replaced by catheter ablation, which is a minimally invasive approach. We believe the catheter cryoablation technique is a better way to remove or isolate the electrical signals coming out of the pulmonary veins, which allows the patient to recover more quickly and return to their normal activities very rapidly. For many patients, the source of the atrial fibrillation may be much more diffuse and go beyond the region of the pulmonary veins. So as a result, we may need to use the ablation catheter in many different parts of the heart. With the advent of robotic catheter systems, we're able to very easily and very controllably place our catheter in different parts of the heart. For patients with very advanced atrial fibrillation, we really sought to have one procedure where we could achieve the highest degree of success. In the hybrid approach, the surgeon comes from outside the heart and is able to treat the areas that are responsible for the electrical heart rhythm. Then we come from inside the heart using these small plastic tubes called catheters. By treating the heart from outside the heart and inside the heart, patients with even the most advanced form of atrial fibrillation, we believe, will have the best results.
I had the ablation about 3 years ago. In my case, it was very, very important from a lifestyle that I be able to be physically active. It was important for me to get the condition treated.
Mr. Burkett's lifestyle changed dramatically after the ablation. He began to be more active. When I saw him after the ablation, he looked terrific. He really looked very fit and had gotten back sort of on the saddle again, if you will. I have a lot of hopes for the future in terms of AFib. I think one will hopefully have better medications that might have lesser side effects, be more tolerable, and be more effective. In addition, I think ablation will get better and continues to get better. And I think the paradigm may indeed change so that we're doing ablation a lot earlier in the course of patients before they even need to be on medicines, in some cases, even cure their AFib early on. So I think the future for AFib is very bright.